So I'm going to do a sort of a talk on how we manage neck trauma, and actually it's probably managed very differently depending on where you are in the world. But in the UK, there are a number of players, so I thought I'd just set out a simplish way of managing it. So just for the people who sit in exams, there's all these esoteric things you might need to know. So the neck and the face areas split up into 3 zones. So it's not intuitive, as zone 1 is actually in the chest, zone 2 is in the neck, and zone 3 is above the angle of the mandible. So the angle of the mandible, the cricoid, are the divisors. Right, so I'm going to start off with a case study. So this was a true case a few years ago when I was a registrar, was involved in managing this, and I'll refer to this case throughout my talk, just to see what we can learn, what we could have done differently. A 42-year-old cyclist, very fit and well lady, in the night, was cycling at quite high speeds, and someone opened the door in front of her bike, and she slammed, or her neck slammed in the top edge of the car door. She was a trauma call and came in C-spine, immobilized. At the time, she was vocalizing with mild inspiratory stridor, and there was this type of mark. It's not the patient, but this type of mark on the neck. So when we assess trauma, we think about 4 things, or I like to think about 4 things: mechanism, what's happening to the airway, what's happening to any major vessels, and is there a pharyngo-oesophageal injury, and we should keep those things in mind at all times. So very simply, the mechanism can be divided into low and high velocity, blunt or penetrating. So it's important to know how this person was injured. And I won't go into the physics of this. When you're presented with a case, those 3 things, airway, vascular, pharyngo-oesophageal injury, should be openly sought in their history. So for the airway, you're looking for stridor, difficulty with vocalization, and the things that I've listed. In particular, the vascular stuff, where there's an open wound, where there's an expanding neck, and don't forget markers of shock. And a lot of people forget about the pharyngo-oesophageal when they're caught up with the airway and the vascular aspects of things. And so it mustn't be forgotten. Hematemesis and surgical emphysema are quite sensitive symptoms and signs. So we should manage all of these patients in line with ATLS guidelines, and with a caveat that we need to look for and control circulation quite soon as well, possibly right at the beginning, along with the airway. And then we have to think about imaging, but that depends on how stable the patient is. At the Royal London, we have a big trauma centre, and we have dedicated traumatologists. But there are other members of the team that are vital. Actually, a lot of our trauma from a head and neck perspective is done by OMFS, but in many units, the ENT will be the first person to call in head and neck trauma. So what do you look for? Some really basic stuff, but you look for these type of things: sucking, bubbling wound, surgical emphysema. Must lay fingers on the patient and just palpate. Obviously, in this day and age, you're wearing PPE, so that will make everything much more trickier and difficult. You're looking for and try and manage active bleed, expanding hematoma, and also pay attention to neurology. And if there is an unstable patient coming, then you really need to mobilize the resources that you have, prepare theatres, get the most experienced anaesthetists available and the most experienced surgical trauma team, whoever they are, and prepare to perform a local anesthetic tracheostomy. While you can, it's good to feel the position of the cricothyroid membrane just above the cricoid, maybe inject a little bit of local anesthetic in preparation for that. And from an anesthetic perspective, we need all the toys out. So, you know, from our perspective, endoscopy, difficult intubation trolley, glidoscope or videoscopes, fiber optic bronchoscope, and tracheostomy sets out. So I'm whizzing through, but actually I'm going to come to the meat of what we need to think about soon. So in terms of indications for awake local anesthetic tracheostomy, first things to think about it, the indications are if you've got a zone 3 sort of craniofacial type injury or a significant laryngeal injury with a teetering airway from a clinical perspective. Endoscopy might have given you a very poor visualization of the glottis. And obviously, if there's an open laryngotracheal sucking wound, then really need to go in and secure that airway with local anesthetic tracheostomy. That's probably the safest thing and the most important take-home message. So the more controversial is the type of trauma that you might think, well, should I sit on it? Should I not? Sort of less injurious type of trauma. And initially, the history of this and what to do about it comes from, you know, way back as far as World War II, where most people were managing penetrating wounds non-operatively. And there was quite, as probably expected, quite a high mortality rate, 35% mortality rate. And then there was this vogue from that period of exploring mandatorily all penetrating wounds that have broken through the platysma. And this was the common practice in the 60s and 70s. And that actually reduced the mortality significantly. And that was the standard of care until the 90s, when I guess cross-sectional imaging became readily available and accurate. And actually, most of those neck explorations were negative and probably unnecessary at that time. Oops. And this is a table taken out of Stellan Moran. Actually, I think the chapter was written by Fagan's team. It summarizes that actually, if you can manage these conservatively, and the big series have managed patients conservatively with close clinical monitoring and imaging with exploration in select patients, and actually the low mortality rate maintains and possibly is even better. So there's some fear about exploring the neck, particularly people who are not experienced. And there is no substitute for knowing your anatomy and having a surgical exposure in this area. And I urge you to go to textbooks like Netter's, etc., just to familiarize yourself with the anatomy. Even for experienced people, it's worth just reminding yourself what structures are going to be under where you might be asked to explore. So remember, mechanism, airway, vascular, and pharyngo-oesophageal. Those are the things that you should keep in your mind. So there are a number of classifications as to how you assess the severity of an airway injury. This is probably the most famous one, Schaeffer-Furman. I'm not going to go through it all, but it's graded from very minor abrasions or minor mucosal compromise in the larynx, all the way to polytrauma, polyfracture, to cricotracheal separation. And essentially, with anything more than possibly a very simple 2, you've got to secure the airway. So type 1, where there's very minor airway compromise, little edema, conservative management. I'll go into what conservative management is in the UK, or in Royal London anyway. And this is it. Humidified oxygen, ideally in H2 environment, nebulized adrenaline, high dose corticosteroids, minimize any other contributors to airway inflammation, and you might want to consider prophylactic antibiotics, and if there's an open wound, give tetanus. A type 2 injury, which is a stable, one of which is a stable fracture. You might want to manage this conservatively if you've got a high dependency unit that are happy to look after these patients. But if there's any doubt, I think you've best bet to secure the airway, either with an ET tube if it's a very stable or fracture far away, or ideally a tracheostomy. I'm not saying ideally. The fracture, depending on its position and its stability, may need fixing, and early repair is advocated to get a good result. So now we're coming to the more substantial injuries. This is what you might be faced with: fixed larynx, fixed vocal folds, a lot of edema. You may not even be able to tell any structure when you look with an endoscope. And if there's any doubt, I think you've got to secure the airway, and be ready to do a local anesthetic tracheostomy. It's an example of the types of injuries that we see sometimes. So awake tracheostomy for me is gold standard here. Cross-sectional imaging afterwards, after you've secured the airway, if there's instability. And then you think about surgical repair, and it's challenging. And it needs to be done by people who are experienced in managing complex airway and working in the head and neck area. I find dislocation of cricoarytenoid joint very, very difficult to manage. I've had 3 or 4 in my career so far, and only 1 relocated. The rest just get fixed and ankylosed. You could, if it's a big penetrating wound, you can go in through the wound and explore the neck. And if there's already a sort of pseudo-laryngo fissure, you might fix the cords there. I mean, this is obviously after you've secured the airway with a tracheostomy. How you repair the framework really depends on your expertise level and what equipment you have. Suturing with a big non-absorbable suture would do, but if you've got mini plates and the equipment, then that's possibly the better way to fix these things. And there will be a lot of scarring and edema, and that will want to close down the airway after your repair. So you might want to think about putting in a laryngeal stent, which is essentially a Montgomery T tube with one of the edges sutured over, and you put it through the larynx and you fix it to the trachea. Obviously, this is all done with a tracheostomy cover, and the patient will have to stay in until that stent comes out. These are usually fatal, but if you are fortunate, or if the paramedics are fortunate to be able to see a lumen, that's probably the easiest intubation they're gonna have. The danger is the partial separation. You may not know there is a partial separation with all the polytrauma, and if you try and secure an airway like this through the top, you could turn one of these partial separations into a full separation, and you lose the airway, and then it's curtains. Obviously, you secure this, and most likely both the recurrent laryngeal nerves have gone. So this patient will have a functionless larynx. They can still eventually be decannulated if you treat the airway appropriately, but they're not likely to have the voice as it was before. sometimes these patients might be better off having laryngectomy for functional reasons. So this is a really nice algorithm in that chapter that I've taken some of these pictures and data off. I think this is recorded, so I won't go through it, but it's in detail. But essentially, when you examine the patient, you're thinking, is the airway stable or obstructed? And if the airway is stable, you have time to examine the airway and perform cross-sectional imaging and make more definitive plans. But if the airway is unstable, then I think we need to move on and get that airway stable. And if there's any doubt about the top part of the airway, then perform a local anesthetic tracheostomy. Don't forget panendoscopy. If you're going to put the patient through a general anesthetic, even if they don't have the signs pertinent to Pharyngo-oesophageal injury, I think it's worth doing a panendoscopy just to exclude that, and also to put an NG tube in. So what about vascular? And that's the airway. So the first thing is pressure, and don't remove anything, don't pull anything out in A&E in an uncontrolled environment. And actually, I've not seen this done in this in the UK, but this is, I've read about it, and it's an option, perhaps where resources are a bit more scarce. That could buy you some time. So the gold, if the vascular injuries is stable, but you're still worried, this is the gold standard investigation to do. 4-vessel angiogram. Not only can you visualize the problem, you can also intervene if you've got interventional radiology. It's also very important in certain areas where you can't get access very easily, such as in the zone 1 and the zone 3, which is the craniofacial area. So you can treat certain types of vascular injury endovascularly. So interventional radiology are very useful in this setting and very important. They could provide some stents, particularly for the major arterial vessels. So if you don't if you don't have interventional radiology to hand, then a CTA and CTV are very good investigations. It's quick, we've got to make sure the patient is stable, and it's pretty sensitive. And it will help you with particularly zone 2 injuries, which you're going to most likely to explore if you are going to explore. There are obviously artifacts, problems with getting artifacts with CT scanning. So what do you do when you're exploring in terms of major vessel? So divide it into veins and arteries, and either ligate or repair. I think the smaller the vein you ligate, if it's the internal jugular vein, you could think about repairing it, but you'd be all right ligating one internal jugular vein if necessary. Probably safer to do so. The arteries pose a little bit more of a problem. The external carotid artery and its branches could be ligated. Don't tie the ligature on too tightly. You could cheese wire that and cause a catastrophic bleed. So it's better to just put multiple ligatures in a row with a biggish kind of suture, and just have 3 or 4 of these in a row tied to slow the blood flow. This will need a vascular surgeon or a trauma surgeon experienced in vascular repair for the bigger vessels. There is a question about what to do about the bigger vessels, to ligate or repair. And the issue is that if a person's had ischemia to the brain for a while, to reperfuse that can cause significant brain edema and further problems and neurological problems. So you might want to consider ligation if the patient's been in a coma for more than 4 hours, or if there's existing cerebral edema on cross-sectional imaging or an infarct. Or if, in fact, if one of the major vessels is already occluded and the patient seems neurologically intact, it might be safer to actually ligate those. On the whole, though, you're going to probably get these patients relatively early and you won't have all this information to hand, so it's probably better to repair if you have, along with your friendly vascular surgeon. So finally, pharyngo-oesophageal, what to do about that? So this is a sensitive sign on a plain chest, plain X-ray. If you've got some air in the prevertebral area, that's an indication there's an injury. And obviously, if you've got surgical emphysema, and there's lots of other symptoms or signs that you might want to look for. But the best thing to do is assume there is an injury and keep the patient nil by mouth. And once they've stabilized from all other aspects, maybe perform a contrast study. Put them on broad spectrum antibiotics, as you might do anyway with penetrating injuries. And if you are taking the patient to theatre, please do perform a pharyngo-oesophagoscopy. So how do you manage these? If you've got a pharyngeal injury, low pressure system, most of these sort of mucosalize and heal with conservative treatment. Esophageal injuries are more problematic. If it's a very small thing, small tear, you might want to see how they're responding through conservative management. Bigger tears will need surgery. So if you're going to go in for surgery, do a 2-layer flap closure. Ideally, you'd put a bougie or some kind of stent in the esophagus to know you're in the esophagus and also to not cause a stenosis. Repair it in 2 layers and put a bit of strap or another muscle layer on top of it to seal it. Really big or atypical or infected or dirty tears, it's probably safer to put a bypass tube in the proximal esophagus, close the in the proximal esophagus to divert any saliva out into the open, and close off the distal esophagus and plan for a big procedure later on down the line. So let's return back to our case study. So what happened? So she was relatively stable, but she had voice change and minor stridor. We performed an awake, she had an airway, but there was a lot of edema, and the decision at that time was to perform an awake fiber optic examination. It was fairly traumatic and needed 2 attempts, but eventually we got it in, or the anaesthetist got it in. So she'd come in very late at night, so performed the tracheostomy the next day semi-electively. And then cross-sectional imaging revealed quite a lot of injury to the larynx fracture, and neck exploration occurred 2 weeks later. So this is a 3D reconstruction of her injury following the tracheostomy. So I'm not sure you can see these pieces of thyrocartilage and laryngeal framework overriding each other. This is what it looked like, lots of pieces floating about in the neck exploration, and we sutured it together. But we couldn't relocate the dislocated arytenoid. And her larynx became quite fixed and scarred, and unfortunately, she still got a tracheostomy 4 years later. In fact, it's 6 years later now. So I only put this example down because perhaps if we'd followed, possibly if I and the team who were involved at the time had followed the guidelines that I've just talked about, she may have had a different outcome. Although I have to say it was difficult at that time. So I just want to finish off by summarizing. Don't forget the ATLS principles. Mechanism, think laryngotracheal, vascular, pharyngo-oesophageal. Don't forget pharyngo-oesophageal. Zone 2 injuries are more likely to need exploration. If the patient is stable, we can perform cross-sectional imaging, and don't forget interventional radiology if you have them available. Have a very low threshold for an awake local anesthetic tracheostomy. In fact, prepare them all for a local anesthetic tracheostomy just in case. And early repair of airway injury is vital, I think, to getting a good outcome for anything higher than a grade 2 Schaeffer classification. And obviously it's a team approach, and we need to utilize the skill sets of all our colleagues to get the best outcome. Thanks very much. I'll take questions.
Thanks, Mr. Ahmed. That was a really practical talk, both for daily purposes and for the FRCS exam. So thank you, really, really great. I mean, what about in the COVID era? Have you had many, and have you changed your approach to it recently?
So actually, I haven't personally, but my colleagues have. And no, I think you have to be practical and use the best PPE that your institution has available. You have to treat every patient as if they have or might be suffering with COVID. And particularly when you're managing airway and getting a tracheostomy. I'm not going to go into that. We've had many talks on that. There's a high risk of aerosolization. Also high risk of, and also I guess the question is, do you do a pharyngo-oesophagoscopy once you've secured the airway in that situation, the COVID situation, because there's a very high risk of aerosolization, lots of secretions there. Yeah, I mean, I don't know, it's a difficult thing to do. I guess you could argue that you've secured the airway and managed the initial vascular life-threatening thing, and you might want to return to do that later on in a more stable environment. Me personally, I'll just, if you've got the PPE, if everyone else is donned and dressed for, doing the other bits of the surgery that's life-saving, then I think it doesn't add much to look into the pharynx and esophagus at that time, if you can.
Thank you.
You'll also be able to see if there's any arytenoid dislocation, etc., and you might be able to, just that esophagoscopy, put in the lip of the scope behind the arytenoid when you're going into the esophagus or the pharynx, may actually push it back
Good tip.
or relocate it.
Thank you, great tip. So a very quick question. Someone asked, what is the name of you mentioned a book?
Oh yes, so Stellan Moran's, well, it might be a new edition, but Stellan Moran has a great chapter on this, I think written by Johannes Fagen's team.
Thank you. Would you recommend vocal fold injection as an alternative to laser cordectomy? Sorry.
Well, I mean, it depends. You mean to paralyze the? I'm not sure. I don't understand that
question. No,
I mean, I guess the aim of laser cordotomy is to open the airway.
An injection.
So it is a goodish question actually, because once you secure the airway, a long time down the line. So I had a patient who had he had a knife, machete put through his larynx, and both his vocal cords, and almost like a cricrotracheal separation, and repaired it. And he was decannulated, but you had to do laser cordotomies to open the airway. And if you open the airway too much, there's a risk of aspiration, and that comes at the consequence of voice. And so what you could do is, and vocalization occurs mostly in the anterior 2/3 or the anterior third or anterior half of the larynx. So you could plump up the anterior half with injectable substances, and core out the more posterior aspects, which will give you the airway that you might need. And I'm working on a patient who that seems to be helping him in terms of his voice.
Great. How do you manage airway granulations? Is there a role for Cipro nebulization? And if so, what doses do you tend to use and durations, please?
I must admit, I haven't used nebulizers for granulation, but what I do is to manage granulations to inject some steroid in the base of the granulation and then laser off most of the granulation, but leaving just a little bit over the cartilage and not exposing the cartilage to set up that chondritis. And do that initially, and if that doesn't work, I inject a bit of Botox to paralyze that side to give it time to heal without getting the trauma from the other vocal cord or the other arytenoid hitting it.
Right.
I'm not. Sorry, I have no experience of using nebulized antibiotics. Not in that setting. Where I have used nebulized antibiotics is in tracheitis. So patients who've had radiotherapy or laryngectomy patients who get a lot of inflammation. We've managed the case together recently, and seems to be good for that. Nebulized steroids. I've used Otolaryngology ointment, which is a combination of steroid and antifungal antibiotic applied to the stoma, and that seems to help some patients with tracheitis.
Great, thank you very much. Regarding just for the juniors, oh, sorry, I've got a poll just flashing up over my questions. When you go ahead for the neck exploration, just for the juniors, do you formally raise flaps or do you just extend the incision locally?
Yeah, I mean, I do both, and I have no, you know, I don't need to limit my exposure to the way the wound has formed. I have no hesitation finding another crease and just lifting her, going horizontally across and lifting flaps to really expose and find out what's going on in the neck. Subplatysmal flaps, go onto the sternomastoid, cut down the fascia and move the sternomastoid, because the money area is going to be in the carotid sheath area. So you want good exposure of that, however way you get it. I mean, if a wound is, you know, just happens to be in a horizontal, in a good position, then I'll use that wound. And then you must cut the edges of the wound, tidying it up, freshen it up, because otherwise you'll get infected. And always leave drains in, not necessarily closed suction drains, but just leave open drains like a Penrose or corrugated drain in case you might have delayed surgical emphysema, and there's an outlet for that.
Okay, great. And is that the same for penetrating trauma in terms of exploration?
Yep. Yeah, I mean, I'd sew up the hole and create a new line, a new incision line, if necessary. At the end of the day, you have to be comfortable and make sure you're safe first, rather than poking holes. And you know, you could go straight into the carotid artery just by poking into a little hole.
Stents, common carotid artery stents, can they be used to treat penetrating injuries of the common carotid artery, or do you need vascular repair and stenting?
Okay, so I haven't really got that much experience, but much will depend on how bad the injury is and whether the patient is needing to go to immediate theatre or not, and the availability of your interventional radiology. I mean, we do have interventional radiology quite readily available at the Royal London, and if you can, particularly for zone 1 sort of injuries in the chest or low down, that's difficult to access, then stents are very, very useful. And it could just be that you could just use a stent and see how things go. I would definitely involve our vascular surgical team, who will probably guide us as to whether additional things like a repair might need to be done. I would have thought that if you're going to repair it, you might not need a stent. However, Um, I guess the most important tip that I can think about in terms of managing arterial is, even for vessels that are branches of the external carotid artery, if it's avoid putting lots of ligger clips in, because they can cheese wire through. And some of these have very high pressure flow in them, so you don't want to, you want to sort of close down the ligature, but don't really go for it, because you'll cut straight through, and then you're going to be in a really difficult way of dealing with that sort of transected vessel. So just put a row of ligatures to slow down the vessel. That's what I would advise.
Thank you. And what makes it tricky for the relocation of an arytenoid dislocation?
Yeah, because if you've, so when you've got an arytenoid, well, it depends on how the forces are after it's relocated, and what muscles are working and what's not working. What makes it the reason why it's very tricky after a day or two is that it starts to fibrose and ankylose very quickly. And once that starts to happen, it's almost impossible to relocate it. If there's an associated fracture in the larynx or the cricoarytenoid complex, then this might be almost impossible to relocate it, because whatever you do, even if you push it back, just won't sit right. In this particular case, what happened was her multi-trauma had actually, both the arytenoid has pulled back, but it also pulled back the superior half of the larynx, pulled it back as well. So you can't just push it back, because you'd have to repair the whole thing and then put a stent in. But by the time we got around to doing this exploration and repair, it was a bit too late for that.
Okay. And you mentioned, I think, in your talk already, but someone's asked, grade 2 injuries, do you always intubate all stable grade 2 injuries for 20?
Yeah, so that's why I've so in the textbooks they say yes, but in reality, in my experience, you might not need to. So so for example, this is a classic grade 2 injury. Sorry, are you seeing this?
Yes,
yeah,
thank
okay.
you.
So one fracture, it's relatively stable and there's not that much airway edema. So actually you might, and we have managed these conservatively, but they must be kept in an environment where you can intervene early if necessary. But anything more than that, I would say err on the side of caution. Occasionally, as I said, intubating these might make things worse. If it's a particularly traumatic intubation, it might displace a fracture or might cause more edema. So that adds another complexity. Do you do intubation or do you do a tracheostomy? I think, if there's any doubt, do a tracheostomy. Probably the easiest thing. Diverts airflow, allows us to heal. And tracheostomy is good for surgical emphysema as well, potentially. It creates a circuit that, a sealed circuit for airflow to away from, a hole that might be there, fistula.
And then you would explore the injury at a later point.
Yeah, not too late, but yeah, I mean, not necessarily. If it's a stable one like this, I might just do another cross-sectional study and see if it's in a good position. If it is, then just leave it. This will fix quite quickly.
Great. And how would you deal with injuries to nervous structures?
Yeah, good question. Very difficult to manage that, actually. First of all, you won't know potentially the nervous injury at the time where you might be exploring the neck. You won't know if there's any recurrent laryngeal nerve or other nerve injury. Subsequently, if I would, once all the trauma is sorted out and you do have, say, a recurrent laryngeal nerve injury, you would probably go on and if you have the availability to do EMG studies and do endoscopy to see if this is a fixed arytenoid rather than a nerve injury, and if the nerve and muscle is still working in terms of EMG studies, and you might consider exploring with a view to getting some tone. You're not going to be able to get the movement back from a nerve injury, but you might get some tone by doing certain things like ansa cervicalis or other nerve transpositions, if you've got the expertise. I must say I haven't done that.
Okay, thank you. Question about blunt injury. Over how many hours do patients tend to deteriorate? I guess it depends on the nature of the injury, but
yeah. I mean, that's a difficult one, but it also depends on the mechanism as well. So, you know, if you could have a patient with an expanding neck, and that's quite obviously an unstable situation. As I said, I mean, it varies, but the key thing is to not necessarily send them home straight away, keep them under observation and see if their symptom signs evolve and have a low threshold for getting cross-sectional imaging to help you. Contrast enhanced, of course.
If the airway is unstable, would you have a low threshold to do an awake local trachea in resus rather than theatres?
Yeah, I mean, if they're going off there and then you know, yes, you would. You'd have to. If you've got some time and a patient is vocalizing SATs are okay, then it's better to be in a safer environment and do it where, you know, you have equipment, etc., runners and people to help you suction or the like.
Great. What about subclavian vessel injuries? Do you get cardiothoracics involved?
Cardiothoracic or vascular. Some of the trauma vascular surgeons at the Royal London are actually cardiothoracic trained as well, so they can split the chest if necessary, and they do have the equipment for it. So yes, so if you I mean, you'd get whoever will be able to manage that in your institution, but this may be one for interventional radiology as well.
Great. Last question, arytenoid fixation, how do you deal with it at a later point?
Okay, yeah, so so actually if their airway and voice is okay and their swallowing is okay, you could do nothing. But assuming they're symptomatic, then I would, and their airway is an issue, then I would do a laser arytenoidectomy, leaving behind the posterior lateral arytenoid, and to prevent aspiration or to help mitigate aspiration. And that may need to be repeated a couple of times, but that usually works. Essentially, you leave the anterior, the vocal process of the arytenoid attached to the vocal cord and core out like a teardrop shape, like this, with the laser. And you leave this part, okay? And that gives you airway and maintains the voice, or should do anyway.
Right.
They are difficult, but they are difficult to manage because they rescar, etc.
There's one more that's come through. I think we've got time for one more. In a penetrating injury that requires surgical repair, if there is no clinical suggestion of upper airway mucosal breach, would you routinely perform a rigid esophagoscopy in theatre? You kind of broached that earlier, but
I would actually. You know, if you're comfortable and you've got a team and you've got kit, yeah, I would actually. You've got a secure airway. It's a good opportunity. You can put an NG tube safely. But you know, obviously, if you don't have that expertise, or if you're not used to doing endoscopies, depends on who's doing it. If a non-ENT team is exploring the neck, then they may not want to do that.
Good, thank you.